Good morning, everybody. We got a very good talk on the incision planning for in head and neck. Now, coming to which are the cases that we should actually consider for surgery and not. Many of the times we realize that our patients come to us in advanced stages, and we are wondering whether we should actually treat these patients because the outcomes are dismal. Now, when you look at the NCCN guidelines, focus on the T3, T4, and the T4a and T4b. Now, when you look at the T3, T4 there and the T4as, they come into the realm of surgery. And when you look at the T4as, also when you look at the NCCN guidelines, they also have clinical trials mentioned. That means there are some even in those that may not be worth resecting. Now, when you look at the very advanced cancers, now these are the T4b, and then there are unresectable. So the T4bs are not completely unresectable. There are some that may be operable, but then there are the T4bs that are unresectable. And we need to focus on these and understand which of these we may want to consider for treatment and not. Now, the problem that we are aware of in our country is 30% of our cancer burden is head and neck, and almost 60% of them would be oral cancers. Now, when you look at the 5-year survival of these patients, it's in 30 and 40%. And the survival is determined on our triaging out a good case, that's a good case selection, in which you can actually achieve a very good surgical clearance, clear the neck nodes, and offer proper adjuvant therapy. Now, when you look at the TNM, the T4a is the ones that are more than 4 centimeters and have a depth more than a centimeter. Now, depth is very critical, and it has come into the TNM. And for the residents in the audience, the depth is an important parameter on how we can have a patient fail locally and whether there is a need for an adjuvant therapy. Earlier, any tumor less than 4 centimeters would have been a T2 lesion. But we know that if the depth is now more than a centimeter, it becomes a T3. Likewise, if you have a lesion which is more than 4 and is more than 1 centimeter, it's a T4 disease. Now, focus on the T4b. These are the very advanced, and the tumor involves the masticator space, the pterygoid plates, the skull base, and or in cases internal carotid artery. So this is the primary tumor. When you come to the nodal disease, again you have a new finding in the TNM which has been introduced in the 8th edition, the extracapsular or extranodal extension. So any tumor which has an extranodal extension is an N3b. Any node which is more than 6 was an N3b, but now if you have metastasis in any nodes with clinically overt extranodal extension, they are N3b. What it means is that your possibility of clearing this disease is suboptimal, and you might require further adjuvant therapy in order to have a good local control. So when you have advanced oral cancers, these are 3 factors that you need to focus on: triaging out a curative case, ensuring an adequate resection, and ensuring that you give timely adjuvant therapy. Now, when you look at the buccal cancers and RNT versus tongue, these are the 2 most common cancers that we encounter in oral, amongst oral cancers. Can you just take my phone? In buccal cancers, they have a late presentation, and early on they involve the masseteric space and can be amongst the cases which are T4b and not worth treating. They often have late nodal presentation, but when the nodes come up, they're very advanced. On the other hand, in tongue cancers, the patients may have early on a neck node metastasis, and those patients can also be advanced and maybe inoperable. Involvement of the infratemporal fossa is fraught with problems, and Shiva is going to talk to us about it. When we look at oral cancers, we need to focus on what is a poor prognostic feature. So when you look at the T4a and the T4b's, this data which was published from Tata Hospital, which I urge all the residents to read, has certain factors that predict a poor prognosis. One is margin positivity. So as a tumor becomes bigger, both at the primary and at the nodal site, your possibility of getting this margin control reduces. Again, higher these tumor spread towards the skull base, your ability to clear reduces. Larger the tumor and extranodal extension again reduces. So when you look at these, I don't know whether you can read this, when these large tumors are resected, the adequacy of margins reduce. So when you look at the T4a and the T4b, the amount of adequacy of margin in the T4b is much lower than that of the T4as. And then when you analyze what is the impact of the margins and the nodes on survival, you find that you are more likely to fail in the patients that have multiple nodes, extranodal extension to the tune of 2.5 times. So when you take on a patient to treat and it's a T4, T4a or T4b, and you have multiple nodes with extranodal extension, you need to understand that your survival automatically drops. 30-40% survival at 5 years for the T4, T3, T4, and with nodes it's 50%, and with extranodal extension it's further 50%. So then truly you need to think very clearly whether this patient you are going to take on for surgery is really worth treating. Neck nodes are the worst poor prognostic features, and this data way back in 2000 showed that the patients who were N2 and N3 did extremely poorly. And when you looked at the overall survival, the ones with N3 barely survived more than 2 years. Again, the same data that we analyzed from T4a and B, the ones that had nodal metastasis did worse off than the ones that had no nodal metastasis. So the T4a and the T4b with and without nodes, the ones with the nodes did extremely poorly. So how do you actually judge that your patient is going to do well? Select a patient that you can have an adequate margin. There should not be gross perineural spread. It should not involve the higher parts of the infratemporal fossa or the pterygopalatine region. The contact should be less than 180 degrees with the internal carotid artery, which we heard yesterday. The patients who have a lower possibility of distant metastasis usually have low volume neck node involvement and don't seem to involve the bone. So when you have patients where the bone is destroyed versus just a soft tissue infiltration, the ones that will have a lesser possibility of distant metastasis are the ones that don't involve the bone and don't have very large neck nodes. So general principles of resection are you need a proper R0 clearance. The minimum margin should be more than 5 millimeters. You need a complete three-dimensional clearance. So the margin, that 5 millimeters, is not just the mucosal margin, it is also in the deep tissue in the base. And the resection with negative margins on the specimen rather than the tumor bed. So this is something that you all need to be aware of. Don't just imagine that you can take off the tumor and then take margins from the patient side. It has been proven time and again that if you have a complete clearance with a negative margin so that your specimen has an adequate soft tissue around it, that is the best outcome for your patient. Now when you looked at the risk factors of the local control, margins less than 7 millimeters, depth of the tumor more than a centimeter, multiple nodes, all are poor prognostic features. And this group from Taiwan has been consistently talking about the extent of spread at the skull base, the number of nodes involved,
and what is the role of the margins. So today, what are your criteria of unresectability? At the primary site, an adequate surgical clearance is not achievable when there is extensive ITF involvement of the skull base, and soft tissue and skin in edema. At the nodal disease, a clinically fixed node, infiltration of the internal or the common carotid artery, and extensive infiltration of prevertebral muscles or skull base. Now this brings us to what is a gray area. So the borderline resectability is something that you will often wonder when a patient is in front of you. Now a patient like this comes to you with an extensive involvement of the skin. It is just edema, it is not fungating yet, and you are now wondering, is this patient worth treating? So you need to look at your ability to clear with margins. Remember, I said margins make a big difference when we are looking at the mucosa as well as the depth. So when you're looking at buccal cancer and assuming that you're going to get a margin there, your skin is now your third dimension. And can I actually clear this skin completely and ensure that I don't have any tumor left behind? As I said, the buccal cancers are very devious. They may look very small, but as they go closer to the retromolar tridone or upper GB sulcus, they tend to get into the infratemporal fossa early on. So you need to evaluate whether they have an extension going towards the skull base. Among the tongue cancers, they tend to infiltrate lower down. They work towards the larynx and go towards the mandible. So if you have a tongue cancer and the tumor extends below the level of the hyoid, you know now that it is getting into another organ, the larynx. Now you are wondering whether it is worth resecting this tumor because now your tumor has gone beyond the tongue and is going into the larynx. So at the hyoid anterior and at the vallecula posterior, you have issues whether you get a complete clearance. And of course, as I said, extensive skin infiltration will impact your ability to get a margin. Now, these are all gray areas. These are not something that is written in stone. And these have been discussed time and again in multiple joint clinics, wherein the experts sit together and discuss whether you can actually do good for your patient. And these are some of the things that we felt were impediment for us to actually ensure a good outcome. At the node again, we discussed yesterday how you need to understand whether the node is mobile or is fixed in a plane or both the planes. So gross extranodal extension is because of the fixity. Because of extranodal extension, the fixity occurs in the surrounding tissue. And an extensive skin and soft tissue involvement and encasement of the artery are perhaps something that we may not want to consider to resect. A little bit about what is the role of induction chemotherapy in these kind of cases. Now, when you have a patient wherein you cannot ensure that you might be able to clear it, you would want to consider some sort of downgrading. You want to reduce the tumor volume and then consider whether this is resectable. So consistently at our center, we have been giving neoadjuvant chemotherapy in these borderline resectable cases in order to understand whether these patients can be brought into the realm of cure. So when these patients were given chemotherapy, we found that about 40% of these could be resected. And the ones that had a response and could be resected went on to have a better survival than the ones that were completely unresected. So this is some data that has now come in with a 10-year overall survival. So what we understand is you need to first define whether your patients are resectable or not. And this has to be with a joint clinic decision with your surgeons, the plastic surgeons, and the medical and radiation oncologists. Because today, what we were unable to resect maybe 2 decades ago, are resectable because we can reconstruct them better. So be very clear that if your patient is resectable, that patient has the best prognosis in comparison to the ones that you would give a non-surgical therapy. All this is possible, but be clear about the definitions that you all have in your institution for what is resectable. You need to understand your limitations are there as far as the third dimension is concerned, but if you can resect it, please go ahead and resect it. The ones that you cannot resect, you may offer a triple drug chemotherapy and reassess them after 2 cycles. 2 cycles is the upper limit for us because beyond this you have only resistant cells left behind. So I hope I've left you with some thoughts about what are my criteria for a borderline resectable disease, and I'm open to discussion.
Thank you, sir, for that beautiful presentation. As you aptly pointed out, case selection and achieving negative margins are very important. Any questions from the audience?
Just one question. Any role of immunotherapy prior or after?
No, absolutely no. Currently, there is no evidence that immunotherapy works. It's in the palliative setting and it's in the second line therapy. I don't know what Shiva has to say.
Actually, as of today, there is no role. But there are a lot of trials that are underway wherein they're looking at immunotherapy in the neoadjuvant setting. I'm not sure it's being looked at in the adjuvant setting, but I'm sure there'll be some trial. If you look up in the internet, it's probably underway somewhere.
But Shiva, clarify, you're looking at an operable disease which you're
This is not for operable. It's in for advanced oral cancers and for unresectable oral cancers. There are trials which are underway, multiple of them, where they're testing neoadjuvant immunotherapy. That's a concept that is being tested. As of today, there's no role. Maybe 5 years down the line, we might have a different answer that we will be saying. And the concept of borderline resectable, as what Sir mentioned, is a grey zone. Not everybody agree upon. But I think there is a concept of borderline resectable. Now, when many believe it's like either resectable or unresectable, because that's where the survival, the hazard discrimination is shown. Now, where does borderline resectable fall here? That is questionable. Nobody has shown that till date. But this concept of borderline resectable I can draw parallels with borderline pancreatic cancers, wherein here the borderline resectability question comes up because of the ability to achieve an R0 resection. We all know that when we have an R plus resection, the prognosis of our patients is going to be worse. So based on that aspect itself, the definition of borderline resectable in CN pancreas has been laid out through consensus. So maybe that has not happened in oral cavity yet. We are yet to reach that consensus. But some believe that, I do believe that there is certain borderline resectable cancers which we may have to treat them we may have to have different strategy. I'm not saying, we probably giving neoadjuvant chemotherapy might downsize and we might be able to get that negative margins. And also, as what Sir said, that with the ability to reconstruct with the newer, advances, that ability to resect has only increased. But even then, we do have a lot of patients, and the picture that Sir showed for borderline resectable was one of the mildest ones. We have cases which are at least 5 times of this, and a young patient coming in, and you're questioning as to whether you can resect this patient. If I have to resect the patient, I have to straight move in that patient on the same day into the OR and try to resect. Because there are other logistic issues also coming to play, not just about the surgical resectability. So there are multiple factors to it.
Yeah, you're absolutely
Role
right.
of neoadjuvant chemotherapy with immunotherapy. That's what medical oncologists decline.
So but there's no evidence to practice it today, sir. That's what that.
So the point why I was saying no clearly was that a lot of people are now using immunotherapy as earlier they were using chemotherapy. And we should be very clear that this is not in the first line therapy. If you can operate the patient, that's going to be the best thing that the patient will have. If you cannot operate, then you need to go for what is as for the standard therapy is concerned. Immunotherapy is still in the clinical trial setting.
Dr. Shiva, you're absolutely right, because the borderline varies. Because I used to assist a surgeon who used to do skull-based for almost every week. So it depends on case, place to place.
The question is whether it should be done. I mean, you can do it, but then we should have our data. Like what Sir said, we are as good as the follow-ups that we can get. Now, if you're doing that resection and if we can show that it is working well for the patient, so be it. Nobody's going to question that. But then that needs to be reported so that others can also learn from it and do something. That's the point.
Operability is a state of mind, finally. We were told jokingly that so long as it's not stuck to the table, you can resect it. But the point is, should we actually do it? Shiva will talk to us about the infratemporal fossa. I didn't dwell on it. Now, you can resect any part of the skull base. You can resect all the areas. You can be safe. Yesterday I showed how carotids can be revascularized and you can be safe for your patient. Last 2 decades, we have seen an improvement in the reduction in morbidity. But that has not translated into improvement in survival. So the more we can resect doesn't mean the more the patients are going to survive. The outcomes have been the same. They've been the same in the last 3 decades and they're not improved. You need something else beyond surgery and radiation. And when the tumor crosses certain barriers and certain boundaries, you will fail in that local area. Neck nodes which stuck to the carotid and have been resected, the local failures in almost 2/3. That means it is at a local site. When we resect skull base, we fail at the site where we are resected widely. And in spite of having very good IMRT, having chemotherapy and radiation, increasing the biological activity of radiation, we still are failing. So select out your patients carefully and do an optimal job.
Yeah, I agree with this completely. If you cannot achieve cure, don't give morbidity to the patient. You are not improving survival. And patient will have a poor quality of life with such major resections if you cannot achieve cure.
This third aspect of a treatment of an advanced cancer is very vital. A timely delivery of an adjuvant therapy is very critical. Often we undertake these large resections, we do very good reconstructions, and the reconstructions fail. And by the time the patient is actually fit enough to receive radiation or adjuvant therapy, it has gone beyond 6 weeks. Now, we have shown consistently for every day of delay of radiation, you fail by 1.2%, a local control rate. So when you say that I will add chemoradiation, you're at the most gaining 10% survival advantage. And if you're lost 10 days, that advantage is also lost. So my job would be to select out a good patient, do an adequate resection and a proper reconstruction, and see that that patient is fit enough to receive radiation on time. And that should be our bottom line. A treatment package of 100 days has been sacrosanct for last 25 years, and it will remain like that.
I think what we have to understand is when for all these extensive resections, there is very limited data on patients' quality of life. Now, we say that we can do the resections, we can do the reconstructions, but there are very few studies which comes out with a quality of life data for such extensive resections. There has been some improvement in survival, definitely. we always are trying to push our boundaries and push the extent of resections that we do. But such extensive resections have shown not too drastic change in survival, and there's absolutely no quality of life data following such dissections. I think there's one medical oncologist, Ian Tannick from Canada, of Princess Margaret Hospital. Some of you might have heard about it. So what they say is, when we offer any treatment to a patient, it has to increase overall survival and it has to improve the patient's quality of life. It has to do both ideally, but it has to do at least one of the two, if not both. So if neither of them is being improved, then we have to look back whether we are giving the right treatment for the patient. So I think such extensive resections technically are possible, but we should also look at how much of improvement in survival and benefiting the patient in terms of quality of life that we are offering the patients is what we need to introspect.
I follow up those patients regularly. The data is not there. That's right.
So the thing is that it will be great that such data should be published for everyone else to understand.
I can relate to that state of mind of operability. When I started my practice as a consultant, so I wanted to operate all cases to realize that at 3 months you have a carotid blowout and a subcutaneous nodule, and now we have been very selective. So it's agree that it's a state of mind operability. When you don't get outcomes in terms of control and quality, there is no point in doing such surgeries.
For locally advanced carcinoma, locally advanced carcinoma tongue, which would require at least a near total or a total glossectomy to achieve R0. What would be the cases where you would consider upfront concurrent chemoradiation in those cases?
Concurrent chemoradiation would be for two reasons. One would be a positive margin, and second would be an extranodal extension. So these are defined criteria for adjuvant chemoradiation.
So in the upfront setting,
Upfront, you want to give chemotherapy?
instead of surgery, if the patient requires a near total or a total glossectomy.
So as on today, I would not consider neoadjuvant chemotherapy for an upfront operable advanced cancer. So when you look at tongue cancers, you have got, in my opinion, you've got three surgeries. One is a wide excision glossectomy, one is an anterior 2/3 glossectomy, and then you have got a total glossectomy. So you need to understand that, is it a lateralized disease? Is it an anterior disease crossing midline, or it's involving the base tongue? Now, if it is lateralized disease and there is edema which is crossing over, like you have this cheek edema, and you want to give chemotherapy to reduce that tumor edema so that you can do a proper hemiglossectomy, in that may be one of the criteria which MD Anderson data also exists, which is a phase 2 study, and that has shown that you can preserve some amount of tongue function. But when the tumor has crossed midline, it's involving the contralateral genioglossus bundle, it's involving the base tongue, extrinsic musculature and the soft tissue, you will not gain by giving chemotherapy. Your margins are going to be the same. So even after chemotherapy, if I'm going to end up resecting a major part or component of the base tongue, I'm not achieved anything with the chemotherapy. In fact, I've lost 6 weeks because I've given 2 cycles, and in 30% of them, the patients progress. So then I might even make that patient who is operable currently inoperable. So in my context, if I have a limited disease seen radiologically, not crossing the midline, but there's tumor edema, when you palpate the tongue, you know that you're going to cross midline to resect it. In those patients, I might give. In a total gloss, no.
So I think what Smriti was asking is, when would we consider upfront chemoradiation in CA tongue patients? Would we give in such borderline resection?
I misunderstood. I thought only chemotherapy.
Yeah.
So chemoradiation, I have no experience in upfront chemoradiation. So
there's one data from TMH which has been published a few, maybe less than a year back in South Asian Journal of Cancer, wherein upfront chemoradiotherapy for such cancers had a median overall survival of 6 months. So if you look at it as per the ESMO magnitude of clinical benefits, that as per their guidelines, if you're offering any treatment and if it is 6 months or lesser, that treatment modality should not be considered. So upfront concurrent chemoradiotherapy in such borderline resectable cancers gives a median of 6 months, which is not, the clinical benefit is questioned.
Smriti, you have any data that you would like to bring forth?
So even our radiation oncologists are reluctant to treat these patients with radical chemoradiation, but we have seen that our results following surgery for these patients who have undergone near total or a total vasectomy, the quality of life is very poor. So
Right.
I wanted to know about
Right.
the experience at your place.
Yeah. But what our data suggests is, if they don't have neck nodes, the survival is around 40%. But if neck nodes are there, the survival becomes poor for NTGs and TGs. That is what.
She's talking about the quality of life of swallowing and speech.
Not,
so those
not,
are things which are.
I think Shiva sir is looking into it. Sir can answer better.
So currently we are looking, it's not a randomized trial, it is just a prospective observational cohort study wherein we are looking at a cohort of 50 patients who have undergone total or near total glossectomy and who have undergone reconstruction with a free flap and a pedicle flap. So we have done, we have completed the accrual, we have done baseline quality of life assessment and assessment at 3 months, 6 months and 1 year. And we're just awaiting the final follow-up of the last patient that is accrued, which will be completed in September. And hopefully sometime early next year, we should be out with the results, which we will be clearly knowing as to whether the pedicle versus free flap, which is offering better quality of life, and in general, what is the quality of life of these patients at the baseline and as they go ahead after treatment.
And during surgery, one should put higher mandibular stress so that the larynx is elevated. That definitely improves the swallowing outcomes. Because the physiology of swallowing involves elevation of the larynx when we swallow. When we cut the suprahyoid muscles, that movement is hindered. So put a higher mandibular stress so that the larynx is elevated. And those patients, I've seen patients with TGs who are swallowing. Surprising, but they are off tubes. Very few numbers. But yes, first study would tell us what proportion of patients actually swallow after these major glossectomies.
So the picture which you had shown that case is borderline with the outer skin nodule. After giving NACT, there is a good response. The nodule is almost gone. So will that margin be the same as it was previous? Does it affect the flap size, sir? Because yes, there are many issues when post NACT we do reconstruction in like free flaps. There are multiple issues which are there. One of them is that the blood vessels are very thrombogenic. Like there will be repeated episodes of thrombi. On table also we have seen. You're giving cisplatin. There is a lot of data in literature saying that cisplatin is thrombogenic. And like I just want to know that if like the flap will be very large because it has to cover the buccal mucosa, you'll deepithelize it, 2-3 centimeters will go there, and then again you have to fold it for the outer skin. Yes, high chances of flap loss, but is NACT actually helping in reducing the size of the flap?
No, it doesn't reduce. That's what I said, that all these are borderline resectable cases. So if you determine that you can resect it upfront and you can reconstruct adequately, you should do the surgery. The ones that you feel that you might not, this patient is palliative. But if I give chemotherapy, he's a young guy, he has no neck nodes, there's a lot of edema, and I might not get a better clearance now because I might remove more tumor, more skin than required. In those patients, I would consider neoadjuvant chemo. But upfront, if my plastic reconstruction surgeon tells me I can do a good job reconstructing this, I'll opt in. And you're very, very right. There's a lot of issues intraoperative also while we are resecting the primary when the patient has received chemotherapy. So the platelets are also affected.
Yeah, very oozy. The fields are very oozy. It bleeds a lot. I don't know for whatever reason.
Yeah. So there is there are a lot of issues related to just giving chemotherapy on plate.
And how long do you wait? Like in breast, I think they wait for 4 to 6 weeks interval. And in your cases, is it like that if you wait longer, then it might increase in size?
The tumor starts growing again. So as soon as the patient has finished chemotherapy, the second or third week we will opt in.
Thank you.
Thank you very much.
Regarding that, regarding the patients who require total glossectomy, we have published our data from our hospital of 165 odd patients with a mean survival of, median mean follow-up of 3 years. And it is like any T4a or T4b lesion that their survival is 30 to 40%. And we have 26 patients that who have follow-up of more than 5 years. We are trying to publish their quality of life, even speech, swallowing, and general quality of life. That is yet to be published.
So there is a large data set from Tata Hospital, over 900 patients, and that is the oral cancer adjuvant therapy study. In those patients, if you see the stage 3 and stage 4 patients, the survival is 55% at 5 years. So we know that most of the patients, the tongue cancers, advanced buccal cancers, they will have a median survival of 50%.
These are the patients requiring total glossing.
Yes, yes.
Dr. Prathamesh, we've seen another group of patients, the younger individuals who do not have any habits with early lesions. We're talking about T1, T2, sometimes T1 also, T2, T3. Margins are all clear. Neck node may be one positive. We have decided to give radiation. And lo and behold, by the time they finish, many a times we've seen this. I mean, I've seen this over a period of 30 years. Everything we have done right, sent for radiation. They just come back with very, very nasty
The
skin
tongue cancers,
Not
mostly
necessarily
their tongue cancer.
Mostly tongue, but sometimes even buccal. They don't have any habits. And they die within 6 months, 3 to 6 months time. And it's very unfortunate. I'm sure in Tata you would have seen a lot. Any thoughts on
So there are a lot of studies which have tried to look at the non-habitual young individual who has a cancer, and they're trying to understand, is it more aggressive? So they haven't proven in literature that these patients will do poor as compared to your tobacco user and an older individual. But we need to look at other factors, poor prognostic factors like perineural invasion, lymphovascular emboli, the tumor host response. So now when you look at the current literature, a lot of debate has been as whether only these TNM and extranodal extension are these the only criteria on which you will give adjuvant therapy. So we now have to risk stratify based on many other features. What is the histology? Is it a poorly differentiated carcinoma? Is there perineural invasion? What type of nerves are involved? What are the margins? Go back and see the MRI. Was it just the T1, T2, or was it going vertically down? So lot of thought process has to go into re-evaluating when we did surgery. Did we actually leave behind something? And radiation is not going to be effective because you may not have cleared it, and those might be resistant cells. So yes, we have all come across these wherein we have burnt our fingers with younger patients, but there is no evidence that the younger patients do worse off than the older.
There is a small subset of patients who, irrespective of what you do, they do very badly. I think that kind of group of patients will have to be selected out. I think we need to do more studies on that, particularly in molecular studies, and proteomic analysis will have to be done to see how they are different from the run-of-the-mill surgeries that we often do, and how do they differ. I think we have also selected some cases. Work is going on. We are doing proteomic studies in those cases. Some of the patients, you just do a buccal mucosa excision, and in 3 months' time, nodes are negative, but in 3 months' time there is extensive cutaneous spread all over the face, and quickly they die. Now, these are alarming patients, and we see that. I think that set of patients will have to be separated out, and they are very distinct. As you said, many of them, in fact, most of them do not have any habits.
Look, there's one small difference in thought about when you said in response to Radhika's question that your margins will not change after induction, neoadjuvant chemotherapy in a borderline resectable tumors. At the same time, you are showing you made them borderline resectable to resectable, and the outcomes improved. Yeah. So you're making borderline resectable to resectable tumors. Does that means that you should take a lesser margin? Actually, I think if we could have achieved a proper margin, we should do it at the first instance. We are calling it a borderline resectable tumor, meaning that we have some doubt about it resecting it completely, and then after giving the induction, you are resecting it, meaning that we shrink the tumor and we took a smaller tumor out. Okay, so actually we should be doing a lesser surgery, but it should be followed by the consolidating treatment, which should be concurrent chemoradiotherapy, which will take care of whatever the microscopic patchy tumor that might be left with. So I think conceptually it should not be the same margin. Yeah.
it should be a lesser margin. Same is the case with your mandible preservation, the Chowker study.
Right.
You have preserved the mandibles, you are shortening the margins. When you say you will go and resect it, the same thing and reconstruct the same flap, I think there's a conceptual.
Absolutely. So that's why this is in a gray zone. I'll draw your attention to the fact that there is a concept called the worst pattern of invasion. Now, when you look at the worst pattern of invasion, it means that the cell growth is not uniform. It's the tumor is not growing concentrically and becoming big. There are few cells that then leave because of the adhesion molecules being less, and they are moving away from the main tumor. Now, conceptually, if I resect this and I leave behind those tumor nests, I will have a tumor recurrence. So I now know that if I have a patient who has a worst pattern of invasion type 4 or 5, I will have to supplement my surgery with radiation. Now, let's look at the patient who has received chemotherapy. This large fungating or maybe about to fungate mass, I give chemotherapy and the tumor shrinks. And I resect it with a cancer redirected margin, meaning I have shrunk the tumor and I have resected with 1 centimeter beyond it, like we all do. Will that tumor shrink concentrically? That was one concept. And two, what is the possibility that I will have left behind cell nests? So there has been a study which has not been published so far, wherein they did a radial cut. Firstly, an suture was marked 1 centimeter beyond the tumor. Patient received chemotherapy. Then the resection was at that suture line, and then that entire specimen was subjected to radial cuts. Then the tumor was analyzed. How did it actually shrink? And then they analyzed there was a complete reduction or there was some cell nest left behind. So there are 4 types of reduction in the way these tumors reduce once you get chemotherapy. In almost 50% you'll do well, and KK, that's where we may help the patient by reducing our margins of resection based on what we are now seeing, like they do in breast cancer. But in the 50%, we will leave behind some cells which are resistant to chemotherapy in the perimeter. And then even with radiation, they may not help because they are chemo-resistant cells. So my worry of allowing a cancer redirected margin is that we might leave behind resistant cells. So like you said rightly, if you can resect upfront, you should do it.
Yeah, that's what. If the surgeon thinks it is resectable upfront, you should do surgery. Only if when the surgeon raises your hands, and that can vary.
Yeah.
Okay, this borderline resectable can vary from surgeon to surgeon, institute to institute. The situation is
absolutely.
It is a variable concept. So, but in your center or where you are working, if your surgeon raises hands and say, see, I can't do this properly, then comes the role of the neoadjuvant chemotherapy, and after that, when the tumor shrinks, if the tumor is not shrinking, there is no role of doing this. If the tumor shrinks, probably you should do with the shrunk margin, and not that, as you say, the patchy deposit should be there. It may be there, but if you are going to operate, you should do a shrunk margin, and you have to believe that this patchy small has to be taken care by the adjuvant chemoradiotherapy. Otherwise, there is no point in doing a big surgery again. Absolutely. And causing the morbidity again with the difficulties of doing a free flap after an induction chemotherapy.
So we know that conceptually we are leaving behind microscopic disease after surgery following chemotherapy. So all our adjuvant therapies will be chemoradiation. We will not give only adjuvant therapy if this patient has received neoadjuvant chemotherapy.
Even if the margins comes negative.
Even if the nodes
are
negative, margins are negative, correct. There is no tumor seen at times, we will still give chemoradiation. Because we know that you will fail in the area that you operated or in the perimeter.
So, you want to make just a comment and a question. Just for all these difficult cases and patients with unknown habits or no habits, just like Dr. Srinath was saying. I think the present trend is to go through proteomics, metabolomics, and genomics, all three together. In fact, I spent 5 years of my life without a pay just to understand these things. Question: should we be imposing HPV vaccines for our teens?
So, HPV disease in our country is unknown, if I may say. And the data that is there in literature, one from Tata Hospital, one from All India Institute, suggests that in oral cancers, it is less than 20%. In even oropharynx, we are seeing in the same figure between 15 and 20%. Laryngopharynx and hypopharynx, it's less than 5%. So truly, in our country, possibly, and this is also reflected in certain Southeast Asian countries, that the HPV diseases are less as compared to the Western population. So maybe this is not related to our genetic pool. It may be more a Caucasian's disease because it's a young white male who seems to be having more HPV diseases. So I'm not sure that just because of this, we need to instill HPV vaccine for all. But yes, in women, the cervical cancer mortality has reduced, the incidence of cancer has reduced. So yes, we need to go the path of HPV vaccine for our young children.